I think people are still kind of filing in while I talk, but I do think we want to get started. Welcome all to the Clayman Institute's 2022 Jing Lyman Lecture. We're glad to see many of you here today. I'm Adrian Daub. I'm the director of the Clayman Institute, and I'm very excited to get to present this event as our first in-person event back. First big one, so a big moment for us. And I don't think we could have picked a better topic, well, we could have picked a different venue, but couldn't have picked a better topic and a more enduring kind of tradition to kick off our in-person programming again after a long COVID-imposed hiatus. Let me first say a little bit about the Clayman Institute, because the Jing Lyman Lecture is quite intimately entwined with the history of this institute. It was founded in 1974 and has since then conducted research on topics related to gender, feminism, race, and sexuality, has brought together generations of interdisciplinary scholars, and has had a long tradition of translating gender research to broader audiences. The Institute sees itself as an incubator for collaboration, engaging diverse groups of experts and scholars to identify and tackle the next big questions related to gender equality. For decades, its research, both the research done in-house and that done by our many faculty affiliates, has affected lasting change. And if you don't know much about us, we invite you to check out our website, gender.stanford.edu, where you can find out about fellowships, about internships, research publications, and much more. So today's event is our annual Jing Lyman Lecture Series, which due to COVID has not been annual, but will be again going forward. It was made possible by our generous donors, and it honors the late Jing Lyman, who was a fierce and dedicated supporter of equality of the women's movement, and was in fact instrumental in founding what was then CROE, what is today the Clayman Institute, back in 1974. Our founding director, Myra Strober, who is with us today, said that, quote, "If it were not for Jing, there would be no Clayman Institute for Gender Research at Stanford at all." Jing, the spouse of late Stanford President Dick Lyman, has been honored in these illustrious lectures since 2010, all commemorating Jing Lyman's legacy and paying tribute to trailblazers contributing to gender and justice in their communities and in the world. Today, as part of this series, we honor abortion providers. Like previous Jing Lyman lecturers, our speakers today have faced and are facing incredible challenges, but they have met these challenges with vigor, with determination, contributing to and continuing to fight for a more just world for all. As we discussed who we would honor as our 2022 Jing Lyman Lecturer, we could think of no one better than those who we have gathered here today. These individuals are standing in the face of incredible odds and challenges, and standing up for the rights and dignity of all women and pregnant people. While the Dobbs decision was a sobering tragedy, today we are here not only to reflect on this new reality, but to lift up the strong leaders who are doing all they can to ensure bodily autonomy and human rights for the majority of the US population. Thank you to each of them for being here today and sharing their experiences with us. Before I introduce our moderator, a few brief announcements. I wanted to draw your attention to the exhibit outside in the lobby called "Focus on Abortions, Americans Share Their Stories" by artist Rosalind Banish, who is also in the audience today. We invite you to mingle and take in the exhibit after the lecture, and thank Rosalind for sharing her work with us. I also should announce that unfortunately we just learned that panelist Merle Hoffman cannot join us today. We're really sorry that she won't be able to contribute to this conversation. Finally, all of you should have found note cards on the armrests of your chairs. These are for Q&A. You can fill them out at any time. Find us and give them to us. We will pass them on to Maura Donegan, who will be reading them out. That's how we're going to do the Q&A, just for bundling questions. Finally, I would be remiss if I didn't acknowledge that today's lecture topic is in many ways central to a heated political climate. I probably don't have to remind you of this in this week of all weeks. I'd like to acknowledge that opposing views are, of course, acceptable, but we'd ask you to be respectful of our moderator, invited honorees, and other attendees, and that disrespect in that regard is not acceptable and will not be tolerated. So thank you all for being here today, and now I'd like to introduce our moderator, Maura Donegan. Maura Donegan is a writer covering the intersection of gender, politics, and the law. Her criticism, essays, and commentary have appeared in places such as the New York Times, the New Yorker, the New York Review of Books, the London Review of Books, and Book Forum. Donegan has been an editor at the New Republic and N+1, and currently writes a column on gender in America for The Guardian. Her first book, Gone Too Far, Me Too and the Future of Feminist Politics, is forthcoming from Scribner. She lives in New York. Welcome, Maura, and thank you for being here today.
Hi, everyone. Thank you so much for coming. I am really excited and grateful to be here with our panelists. Right now is a particularly difficult time to be an abortion provider. You know, abortion providers have long been the target of antagonism, but there's right now a particular amount of stress and demands on their expertise and their time. So I'm really grateful to them for sharing some of that with us today. And I'd like them to come on out and let's get started. So Catherine Brown is, well, come on, guys. And I'll join you all here. This is very comfortable. So Catherine Brown, the first of our panelists, is a board-certified obstetrician and gynecologist and a board-certified complex family planning specialist. She is an assistant professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at UCSF. She's assistant director for health and wellness at the Black Women's Health and Livelihood Initiative and medical director of the Black Wellness Clinic at UCSF. Her work specifically focuses on the care of Black women and birthing people. Dr. Brown, thank you so much for being here. Our next panelist is Colleen McNicholas, who is Chief Medical Officer of Planned Parenthood of the St. Louis region and Southwest Missouri. She joined as the first ever Chief Medical Officer in 2019 after a decade in academic medicine. As an OBGYN and specialist in family planning and abortion care, she lives out her personal and professional commitment to abortion access in many ways. She has provided clinical care in 4 states across the Midwest and South. Dr. McNicholas believes that a physician's advocacy voice is as important as their clinical and surgical skill. She has grown into an unapologetic and vocal advocate, engaging in every available medium. She has been the plaintiff to numerous challenges of state and federal laws and regulations, and has testified in the state capitol and in front of Congress in defense of patient-physician relationship and the importance of using science and evidence in the creation of health policy. Dr. McNicholas, it's really great to have you. And finally, Bria Peacock is an OBGYN resident physician who recently authored A Black Abortion Provider's Perspective on Post-Roe America in the New England Journal of Medicine. A Georgia native, she has dedicated her life to individuals and communities affected by adolescent pregnancy and high rates of HIV and STIs. She has centered such communities in her work and used her station to be a voice for vulnerable populations wherever necessary, through policy, research, community service, and patient care. Peacock is the founder of Sheely Augusta, Sisters Informing, Healing, Living, and Empowering, which is an advocacy group dedicated to teen mothers and teen girls. Thank you so much for being here, Dr. Peacock. So I think, I'm really interested in hearing about your work since the Dobbs decision, which has so changed, the landscape of abortion access and abortion care across the country. But first off, I want to know from each of you how you began doing this work. What called you to be abortion providers?
So I am a Georgia native through and through. There are many challenges with being a Black girl raised in Georgia, as well as coming from a Christian family. My sister was a teen mom, and so was my grandmother. She had my mother at 14 years old. And I know very well the consequences of not being able to have reproductive choice over your own body, and that could be perpetuation of poverty, intergenerational curses, and I decided very early that I wanted to be a voice for women, and Black women in particular. I then decided to go to Howard University for college, and I worked at Planned Parenthood. There, I fell in love with advocacy in the community as far as sexual health and going into the schools and talking to youth about STIs and really understanding their reproductive choices. I brought that lived and community experience back to medical school, and as a first-year medical student, I founded an organization for Black teen moms and teen girls, really bridging that gap between not having any sexual health education really in the schools in Georgia and providing support for adolescent parenting moms and people who are trying to decide about what they were going to do with their pregnancies. And so now at UCSF, I came all the way to California to be trained in abortions so that when I am done, I can go back to Georgia and provide that care.
Thank you. Dr. McNicholas?
So I think for me, it was sort of an evolution over my sort of experience and training to be a physician. So I grew up on the south side of Chicago, then I went to medical school in a rural area in Missouri, which was a whole eye-opening experience for me for many reasons. And then I did my OBGYN training. Could you try again? My watch is talking. My OBGYN training in St. Louis, so more urban, but also in a state that was incredibly difficult to have access to the full range of reproductive care. And really through my training, Missouri was already becoming and living what we now call a post-Roe reality. And so there was just example after example of how unqualified elected officials were legislating and regulating basic health care. And so for me, that was a real calling an opportunity to fill a space, I thought, that was being occupied by folks who didn't have the knowledge to be doing so.
For me, I came to medicine from a point of wanting to be an activist and a point of social justice. And so when I went to medical school, I don't think I knew that I didn't know I wanted to be an abortion provider per se, but as I became really passionate about women's health, it really just was something I felt called to do, and I never really looked back from there.
Thank you. I ask because this, and we spoke about this a little bit earlier, but I ask because, being an abortion provider is necessarily different and often, I think, a lot harder than being another kind of physician. So you guys all chose a path of work that is, places more demands on you, on the kind of professional expertise you have, the kind of needs that your patients have, the kind of obstacles you face in doing your jobs. And it seems like what I hear from all of you is that and what I hear from a lot of other abortion providers as well, is that there seemed to be like a moral calling to the work. And I think part of why it seems like so morally urgent is precisely because it is so hard, right? Like, Dr. Peacock, Dr. McNicholas, you both spoke of observing the obstacles in these communities where you were working to getting this care. And Dr. Brown, you spoke of like a desire to enact your social values through your work. I wanted to know a little bit, like before Dobbs, when Roe was still standing or technically standing, what were the obstacles that you were facing to providing this care under that Roe v. Wade status quo?
So I can go first. So I will say that my work as an abortion provider has always centered access. And so I live in St. Louis. I currently provide, our Planned Parenthood provides services to Missouri and Southern Illinois. But prior to that, I was also traveling to provide care in Kansas and in Oklahoma. And I will say that, and this is probably universally shared amongst the three of us, but despite the difficulty of the work that we do, that 100%, or I would say 99.9% of the difficulty is external to the actual work that we do. And it is such rewarding work with each and every individual patient. The impact that abortion provides in their life is so profound, despite the fact that the technicality of our work is fairly simple for most of them. Most of them don't need an exam. Most of them don't even need us to touch them. It's such simple care from a healthcare standpoint, but makes such a profound impact on each one of their lives. And so, as folks think about how difficult abortion care is, I like to remind them that difficulty comes from really outside of our exam room, and that it is really quite simple care. And I think what keeps at least me coming back is the real privilege of, in just a few short minutes, being able to give back something to those patients that is so profound.
I totally agree. I think there's such a richness in what we do. I feel really blessed to be able to do this work and to have found a profession that I really feel a calling to, and where I get to connect with the patients and the people that we have the privilege of serving was in such a deep and moving way. In terms of like pre-Dobbs, I think that there were, I feel also really privileged to work in California, where, our access and the struggles that we have are not nearly what there are in other states, including states like Missouri. But there have always been access issues. Like, it still takes, even in California, there are many places where I have many patients who travel 5-6 hours to come get their abortion. They take time away from their job. They have to have people take care of their kids. They have to pay to stay in a hotel in the Bay Area, which is expensive. So there are still many roadblocks, and I think those existed before. They still do. Across the country, Medicaid doesn't cover abortion care for most states, and that existed. That is still a huge access issue, as people have to try to afford abortion care themselves, and that existed too prior to Dobbs.
I completely agree with both of their statements. I know in Georgia, and we were talking about this earlier, in my family's hometown, Cordial, Georgia, watermelon capital of the world, called to fame. We're 2.5 hours south of Atlanta, and a lot of people don't drive because it's such a small town. You can walk to work. And so when thinking about access to health care, half of the counties in Georgia don't even have an OBGYN, let alone an abortion clinic, and many of them are in Atlanta. And Georgia's a big state. And so if you don't have a vehicle, you work in a factory job like many of my family members, and you can't get time off, there are so many barriers to healthcare, just being where you're from, and then let alone if you have racial inequities and gender inequities and things of that sort. If you are trying to find childcare, you can't have anybody watch your child for a couple of days. So there's so many different barriers on top of what they were just discussing, especially in states like Georgia.
Yeah, Dr. McNichols, I was grateful that you pointed out that the complications around abortion care are typically not medical, right? I was embarrassingly old before I realized how medically simple most abortions really are. These are, very brief procedures for which there might be only local anesthesia or no anesthesia, and often, increasingly now, I believe a majority of abortions in the United States are medication abortions, which don't, as you were saying, don't require any physical contact from a physician whatsoever. It's a series of pills. So there's the medical simplicity compounded with a quite extreme, political complicatedness, right? So, we're talking about these obstacles for your patients, such as massive transportation needs, like Dr. Brown was mentioning, people having to travel 5-6 hours or come in from a different state, or these transportation deserts, like Bria was speaking about, how it's impossible to get to the clinic if you don't have good transportation and if you need things like time off work or childcare, right? But all of these are artificial. There's nothing about an abortion that requires it to only be conducted in these very specialized clinics that are only in Atlanta. And there's other kinds of medical care that might be more complicated that somebody in that kind of community could access much closer to home, right? So these are artificial, medically unnecessary, politically imposed barriers, right? And there's a lot of barriers that have been in place upon your patients pre-Dobbs, but also upon providers pre-Dobbs, especially in states like Georgia and Missouri. Can you tell us a little bit about the requirements that were in place pre-Dobbs on you as abortion providers that maybe, a physician providing a different kind of medicine wouldn't have had to go through?
When I was getting my medical education, because I was in medical school in Augusta, Georgia, now I'm a physician in California, so my providing abortions is not as limited. There was where I was, we were not allowed to perform abortions. We were not allowed to talk about abortions. And in the hospital where I was trained, you had to have a very clear medical reason to perform any pregnancy termination, and it had to go before a ethics committee. So it was a very hard experience for everyone involved.
So Missouri has for a long time been living a post-Roe reality. So we were the only abortion clinic in the state of Missouri for several years prior to the Dobbs decision. And Missouri had really taken every avenue, legislative, regulatory, political, to try and limit access, and successfully so. So we had a variety of different legislative attacks, many of which Dr. Brown mentioned. So bans on both public and private insurance. So if you are employed in the state of Missouri and you have private insurance, there is a law that prohibits your private insurance from covering your abortion care, not just your public insurance. We had bans on we had parental consent. We had gestational age restrictions. We had a whole host of what are called TRAP laws. So those are targeted regulation of abortion providers, which are a specific and unique and quite clever subset of laws and regulations around, for example, building codes. So regardless of the kind of care you're providing, say you're just providing medication abortion, you still were required by the state to be providing that care in a space that was consistent with somewhere where you could do major abdominal surgery, for example. And these kinds of laws are specifically intended to close clinics down, right? You cannot retrofit a small health center to be consistent with a hospital code, right? And so Missouri really had the full spectrum of all of those regulations prior to Dobbs. We had waiting periods, 72-hour waiting periods. Your consenting had to be done by the same physician who would ultimately do your procedure, which when you consider the fact that people are driving, 4 hours for their consent visit, going home, they don't always have the capability of coming back exactly 3 days later, right? They have to negotiate another day off of work and more childcare support. And so Missouri, in many ways, was living this post-Roe reality for several years, even before the Dobbs decision. And folks were on the ground were figuring out how to get them to other places, and abortion patients were figuring that out themselves too.
I spend so much time on the pre-Dobbs reality because I think, in this long hangover of these months after the end of the Supreme Court term and the reversal of Roe v. Wade that we saw this June, there's a tendency, or at least I have this tendency to sort of like romanticize what was lost, right? Like, oh, things were so great when we had Roe v. Wade. And the fact is that Roe v. Wade was actually quite quite a low bar, yeah. And it left, especially after the Planned Parenthood versus Casey decision in 1992, which enabled states to impose much greater restrictions on abortion access. It left these large loopholes for hostile state governments to impose burdensome regulation that was, not relevant to the medical reality of abortion, but very relevant to the political reality of how abortion was being used to gain and enforce power in those states. So I kind of wanted to, before we moved on to the post-Roe, just get a little more of a sense of what each of you would feel like justice for your patients looked like. Like what is the standard that we should keep in mind as we negotiate this, lessened reality? Like what is your abortion utopia?
Abortion should be free and accessible to everybody who wants to access it and needs to access it. I guess I'd start there. It also doesn't need to be siloed. Like it's been really siloed into just being provided in certain clinics. And it can just be a part of everyone's care. You don't just need to be an OBGYN. You can be a midwife. You can be a physician's assistant. You can be a nurse practitioner. You can be a family medicine physician. You can be an emergency medicine physician. You can be a lot of different people and provide abortion care. And I think just expanding like who provides abortion, destigmatizing abortion, and a world in where it's really just free and accessible to all who need to access it.
We don't have to say anything else.
That's a hard act to follow because I completely agree with all of that. I think abortion is a human rights issue. I think every person should be able to decide when and if they would want to reproduce at any time. No ifs, ands, or buts. It shouldn't be a tug on heartstrings every time we're talking about abortion. I want to take away the shame that some patients have and even uplift some of the joy some people have or freedoms people have after making such a decision about their bodies. And so it's more of a social thing for me.
And I guess I would just round it out by saying abortion is just healthcare. Like we just look at it as another piece of healthcare, right? We were talking earlier, we don't ask folks to defend their colonoscopy or their, cardiac surgery or whatever else, right? But yet we find ourselves in a space where we are asking people to defend their need and right to access this piece of basic healthcare.
So in June, Roe v. Wade was overturned, and this kind of low bar got even lower, and this ideal of, this faraway ideal of free, accessible, destigmatized abortion care was sort of pushed even further over the horizon. And I wanted to hear from each of you about, and I'm sure we could fill the evening on this, but I wanted to hear from each of you about how your practice has changed and how things, Dr. Peacock back in Georgia have changed, how things have changed in Missouri and Illinois, and how things have changed here in the Bay Area, because I think there's been, quite a shift in the amount of demand, the kind of demand, and really the variety and intensity of need over just the past few months. And I imagine it looks quite different in different parts of the country.
I can say personally for me, I'm still director of CLA Augusta, and a lot of the calls that we get, because we're the mainstay group for just reproductive health and education for adolescents in that town, so in Augusta. And a lot of the calls that we're getting now is about pregnant teens needing support, trying to figure out what to do if they want to have an abortion. If not, the counseling, how to get there, the money, all the things that we talk about with that adolescents have a hard time accessing health care, period, let alone abortion access, which is why they're my mainstay focus in the patient population that I won't say care most about, but focus on, because they are so vulnerable. So that's what I've gotten heightened calls of trying to navigate how to not only counsel these teenagers, but trying to get them to go, trying to figure out how they can get to places, and doing counseling from afar. And then what was the other part of the question? I can't remember. I think that was it.
I was just wondering how it had changed since Dobbs, specifically in Georgia.
Yeah, I'll just stop there.
So for us, obviously Missouri was the first state post-decision to enact its trigger ban. And when I say the first state, it was about 35 seconds after the decision was released. Our Attorney General got on Twitter and said, the trigger ban is in effect, meaning that all of Missouri lost access to abortion. Having said that, there are not a whole lot of pluses to having been an abortion provider in a state like Missouri for 10 years, but I will tell you, this is the moment, right? Because we were planning. We had been planning for a year, and so we had opened end of 2019 a large health center just on the other side of the river between Missouri and Illinois, and so we got to work preparing for what would be the inevitable increase in volume. So before Dobbs, we saw about 350 abortion patients a month, and we now see almost 1,000 abortion patients a month. Before the Dobbs decision, about 4 to 5% of those patients came from outside of our bi-state area, so not Missouri or Illinois. It is now 50%. So 50% of the people that we see every month come from Texas, Tennessee, Georgia, Arkansas, Florida, Kentucky, Kansas, all around. We have had to change a lot about our operations. We now run a health center that is 6 days a week, 10 hours a day. And despite that, we still have wait times that have gone from 2 to 3 days pre-Dobbs to 2 to 3 weeks now post-Dobbs. And totally predictable, and also preventable because of those increased wait times, fewer places for people to go. We've also seen people push to later in pregnancy. So we've seen a 200% increase in the number of folks who are seeking abortion in the second trimester. And so folks who wanted medication abortion are too late to have that. People who could have had an earlier first trimester abortion just don't have, there is no place to do it. And so I think we are, we're seeing the very predictable consequences of so severely and so quickly limiting access.
So here in the Bay Area, I definitely see a handful of patients come from out of state, and they're coming from further away now. So from Texas, Oklahoma, Tennessee, a couple places I've seen people come from. I think we have the capacity to see and help more people, and I hope that in our state legislature we get more ability to, as physicians, to be able to provide care across state lines, because right now we're slightly limited in that when we're doing telemedicine. Some states like Massachusetts have actually expanded what their physicians can provide care across state lines through telemedicine. So that would really expand abortion access if we were also able to do that. We have also worked to train OBGYN residents who lost access to abortion training. So we've had a number of residents come from Texas to train here and get that training. That is a huge issue. That's the future of OBGYN residents and the lack of access that they're going to have to training because of these abortion bans that are in place is going to leave the next generation of OBGYNs less well-equipped to provide this care. So I think there's more that we can do. For the patients who've been able to make it to California, it's a long distance. It's expensive. There's a lot of barriers that you have to overcome to even be able to make it here. And so I think, we really need more support to be able to facilitate people to get here if this is the best place that they can come to get their care.
Yeah, this is interesting because you guys are bringing up what is clearly just a bottleneck of demand that's meeting not enough providers, just not enough supply of abortion providers, right? So like Dr. McNicholas, you're telling me you've got a clinic open, 6 days a week for 12-hour days? That's a lot of abortion providers that you need, right? And at some point they have to go home and sleep. And if there's also restrictions on how to provide this kind of medical education, and very limited and probably more expensive places where that education is available, that says to me that this is going to be a supply demand that's only becoming greater. So Dr. Peacock, you said that you actually chose to come to California to do your residency, specifically to get abortion training. So what are you learning here that you couldn't learn in Georgia?
That's a loaded question. So just like Dr. Brown was saying, the training that we get here is especially important to the field of obstetrics and gynecology. So the 20-minute procedure that we do to perform a first trimester abortion is the same that I would provide to a bleeding patient in the emergency department that's having a spontaneous miscarriage. And so
This is a DNC?
yes, exactly. So it's a huge part of what we do as OBGYNs, and it's not just specific to abortion care. So we're losing a huge part of our training as a whole as OBGYNs, which is what needs to be talked about as well.
So wait, I want to make sure I'm understanding you. You're telling me that people who are studying medicine in Georgia aren't being taught how to manage a miscarriage?
We have a 6-week abortion ban in Georgia now, post-Dobbs, unfortunately. And you're able to do DNCs, right? But as far as the amount of DNCs and DNEs I'm able to do here or at UCSF and the amount that I would have gotten at Emory or Morehouse or MCG are very different. And we know that a lot of the training is just muscle memory and numbers and being able to feel comfortable doing the procedure. So when I return back to Georgia and I decide to go back to rural Georgia and work at a hospital, I'll be very competent in knowing how to perform that procedure for emergencies as well as for abortions. And that's what I really wanted to do, and that's why I came all the way out here.
So you're saying you'll have done it a million times.
Yes.
You'll be really confident.
Absolutely.
You
Even
will-
now, yes.
Yeah.
Even now, yeah.
And that's something that if you're only allowed to perform that procedure in your training under very specific, narrowly, legally defined circumstances,
Exactly.
you just don't gain the experience.
Exactly.
And that's, I'm sure.
Detrimental to patient care.
Yeah, and that's a problem that is happening at scale with all of these medical students who are looking to gain this skill and are.
Well, residents and resident physicians, fellows, we're training the next generation of leaders, and unfortunately, a lot of people have been foregoed that experience, and it's going to hurt us later on. Yeah.
And Dr. Brown, I wanted to talk to you about this as well because you're an educator of medical students and you're clearly very beloved. And I wanted to get your thoughts on what it's like to teach abortion care after Dobbs. Do you see more patients interested in learning this, or are people more afraid? What's the landscape like now?
Well, I think I see a very, we're here in the Bay Area, and I also will say I think UCSF medical students are very, they came here as activists and warriors, and they still are. So I think they are even more excited to learn about abortion, how to do abortion, and are more excited to just become advocates and get the tools to be advocates. So I will say that's the case here. I don't know how it is in other places. I have colleagues who are medical educators in some other places, and they have not met such, their abortion lectures haven't been so well received.
How so? You also mentioned that, touching back on this sort of supply of providers problem, that one of the things you were interested in was in expanding the kinds of providers who can provide abortion care. So making it not just doctors, but other sorts of providers as well. Could you expand a little more on that?
Yeah, absolutely. So in California and in many other states, advanced practice clinicians can provide abortion care, and so I am working on, with other leaders at UCSF, are working on training midwifery students and midwives to provide that care. Right now, it's really important to connect people who want to provide abortion care to the training and the access to that, so that they can expand access and continue the work.
And is this something that is, we were talking about how this is typically very not medically intensive or complicated care to provide. So is the fact that it's normally provided by MDs, is that I guess I'm asking, why is there not a bigger array of abortion providers already?
Yeah, it's a loaded question. I don't know if I should be the only person to answer this, but I mean, physicians probably have a history of co-opting stuff that they don't need to. I mean, in obstetrics specifically, we've done that before around labor and pushed midwives out. I think a lot of the abortion tradition is in midwifery care as well. So I think that's a piece of it. A large piece of it is also just the same restrictions that are put in place other places. It's just meant to limit access and who can get access to abortion, and that's been put in place across the country.
Yeah, I would add that, initially in this country, the criminalization of abortion actually came at the hands of physicians, and it was really around scope of practice, as Dr. Brown was saying, that physicians were upset that other practitioners were providing this care, and so really actually led the charge in criminalizing abortion. And so I personally feel that physicians now have a outsized responsibility to make sure that, that we are fixing this in this moment. And then, I was going to say something else and I don't remember. But here's the other thing I would say is that I think, in addition to not having a skill set in our upcoming physician leaders, the other thing I think that will be a real loss to medical education is the opportunity to develop empathy in a way that that we don't provide really concentrated experiences for physician learners, like abortion provides. When you, even if, so prior to leaving academia to come to Planned Parenthood, I was training a lot of residents in Missouri, most of who don't go on to perform abortions, but all of whom go on to be physicians who understood why people need abortion and were able to have and grow a sense of empathy around this issue that allowed them to be better physicians. And so we are going to be robbing an entire generation of physicians from this, I think, unique opportunity to learn and develop empathy, which is not, it's not something we can teach from a book, right? It's something you have to spend difficult space and sit in difficult space with patients to really grow, and we're going to lose that too.
I'm interested that you bring up empathy for your patients because, because abortion is so stigmatized and because it is made so inaccessible, it strikes me that you guys are all providing care, this kind of care, and maybe particularly when you're dealing with people who are young, as Dr. Peacock's specialty you're with people in maybe an even more vulnerable moment than a doctor is normally with a patient, right? What kind of challenges does that present to you in terms of your bedside manner, in terms of how you conduct yourself toward your patients? How is that different from other providers? What emotional and social skills do you need as abortion providers that other kind of physicians maybe don't need?
I think medicine can sometimes be paternalistic, and as abortion providers, I think we are the exact opposite of that. We understand that our patients have autonomy and choice, and we respect that on all ends, and I think I can speak for everyone when I say that. I think that's a big difference. Also, not looking at the patient as a patient, but also as a whole person, understanding that abortion has so many layers and barriers to access, so many avenues to get to that decision. And so knowing that as a whole also makes you look at the patient as a whole person as well.
I'm interested that you talk about this holistic approach to your patients in their lives because, and Dr. Peacock and Dr. Brown, I know this is a part of your work. You're also really looking very much at the patient as sort of a subject of these social forces, right? You're looking at somebody who is experiencing medicine in a specific way because of how they're situated, by their race, by their class, by their gender. And I wanted to talk a little bit about Black women and abortion care and Black women and reproductive justice, because I think that's, it's a very peculiar part of the abortion conversation, the way race gets deployed or ignored by each side, sometimes compassionately and sometimes nuanced in nuanced ways, and sometimes quite cynically and reductively. So I wanted to know how you guys feel like racial justice plays into your own work.
I guess I feel like it's pretty central to my work. I think it's central to how, I think it's central to how Black people walk through life as in America, in everyday life, and certainly as a pregnant person. So I think you can't talk about pregnancy and being a Black person without talking about race and racism, and that is central to the work we do.
I always go back to history. I think, what I do know is I center myself as a multifaceted Black woman, right? That's how I describe and label myself, because there's so many layers to Black reproductive health when you're thinking historically about forced sterilizations and actually the origins of obstetrics and gynecology in America, and the loss of bodily autonomy once the transatlantic slave trade was ended and we had to continue to reproduce enslaved people to continue to have slavery in this country. And then that's when the midwife shift went away, and then doctors included themselves in the reproduction of Black women. So that's where we started here in this country. And so what we're talking about now is not new. And so when I walk and understand, when I walk with that knowledge and understand that, I can center that in my work with my patients who also understand lots of things that has happened to Black people and their bodies in this country. And you can't overlook those things when you're talking to one specific person, right? When you're talking about access to health care and lack of, when you're talking about forced pregnancies, when you're talking about maternal mortality rate, I can go on and on and on. We can be here all day. But yeah, it's a huge part of what I do, or we do.
I'm glad you bring up maternal mortality, because we know, as in Dr. McNicholas, you were talking about this earlier with us as well when we had this very fun conversation that most of you didn't get to come to, so I'm sorry I keep bragging about it. It was very fun. But Dr. McNicholas, you also brought up Black maternal mortality and the high rates of it, and I think there's also something to be said about the fact that we also know from our research that Black women don't just have worse health outcomes, they receive worse care. They are not treated with as much attentiveness by a lot of medical professionals as other patients are. So I'm wondering how you work with your patients, patients who have maybe had a bad experience with a gynecologist or an obstetric care provider before? Like, how do you, situate yourself in that social history and that personal history and try to establish more trust?
I try to make space for people to lead with listening to them, learning from their lived experience, and trusting what they tell me, and trusting that they know their body, have the answers to, what the right solutions are for them.
I completely agree. I can't tell you how many times I've walked into a black woman's room or a black teen and they're like, "You're my doctor? I can't believe that." And it grounds me every time, because I have walked this world as a black patient and have felt unheard. And so I can put myself in that person's shoes and think, what would I have wanted in this moment? And so I try to do that with every patient encounter.
And now that we have sort of come around to the patient experience, I think, we spoke a little sort of at the top of the panel about obstacles for providers, but we've also got a lot of obstacles for patients, right? Like Dr. Brown, Dr. Peacock, you both talked about transportation. I'm sure this is a huge issue for Dr. McNicholas's patients as well. And I think, when these bans accumulate and when these distances become greater and greater, that people have to travel and the time investment becomes longer and longer, also the costs are going up, right? This is like every mile is money. Every day delayed is money. Every hour that you can't be at work or that you have to have your kids with somebody else, that's all money. Thank you. So I wanted to ask about, as we maybe move towards the Q&A, I wanted to ask about how you guys are trying to provide all the resources that your patients need to make sure that everybody gets that care and gets to keep their health and their lives in their own control.
So one of the things that we intended to roll out post-Dobbs, but sort of had to fast forward a little bit when Texas actually, months before the Dobbs decision, decided to eliminate access for that very large geographic area, is what we call our regional logistics center. And so for any patient who is coming to Southern Illinois for abortion care, regardless of where they're coming from, we offer them a case manager who will then essentially walk through with them any potential barrier they might have from the time they make that appointment to the time they return home after their appointment. And some of the things I will say we did a good job predicting, right? Like travel, right? How are you getting here? And not even do you have a car, but will your car make it 800 miles here and 800 miles back? So some of the things were fairly obvious we were able to figure out. Some of them less obvious. So I'll share a story about a patient that we took care of. And this is actually, again, one of my favorite stories to demonstrate how abortion care intersects with so many other areas of our lives. But this was a woman who was coming to us from Mississippi and called her case manager at 2 a.m. to say, "Can you change my ride share so I can get to the airport right now?" And her case manager said, "Your flight's at 11 o'clock. You don't need to go to the airport right now." And she said, "Yes, I do. He's gone. It's my only opportunity," right? So changed the ride share. She sat at the airport for 10 hours waiting for her flight, had totally uncomplicated abortion care with us, and then called her case manager again 2 hours before her flight to say, "I'm going to miss the flight." And she was crying and crying and crying. And the case manager said to her, "It's fine, whatever. Like, do we need to get you care? Is that why you're going to miss the flight? Like, what do we need? We'll just reschedule your flight." And she simply said, "Look, I have only the clothes on my back, but I'm not going back. And this abortion has saved my life because this is my opportunity to get out of here." And so there are so many things we also didn't think of. We redid an education room in the health center after we heard from patients that they needed to bring their kids with them. They didn't want us to find somebody to take care of their kids or to give them money to pay somebody to take care of they just wanted to bring their kid with them, right? So we made an education room a family room. So now you can have your abortion visit in this space with your family and your kids, and then, go back home. And so, much to what Dr. Brown was saying, I think it is incredibly important that we're just listening to people, right? Because it is hard. We're never going to make it perfect. We're never going to meet all their needs. It's still going to be hard. But if we're listening, then I think we can do a reasonable job of reducing some of those barriers.
This brings me to one of the things that I wanted, I was thinking about asking you as we wrap up. And thank you, first of all, thank you guys so much for this wonderful conversation. I have learned so much over the course of this afternoon from the three of you, but I wanted to know what abortion gives to your patients. Dr. McNicholas, you were talking about these things you hadn't thought of, and these kinds of ways that an abortion can free or empower somebody that maybe hadn't occurred to you before. Have you guys encountered anything like that? Have you been able to see what abortion does for your patients, and why do you keep doing this work when it's so hard?
I can say, for me, over my short life so far, I've had lived and community experiences outside of being an abortion provider that make me continue to do this work. But I know for a lot of my patients, it is freedom. Abortion changes the trajectory of a lot of the girls that I work with. Some of them were forced to remain pregnant. Some of them were forced to have an abortion. And so for me, it's about reproductive justice overall, but we're talking about 10, 11, 12, 13-year-old, 14-year-old girls who are having to make a truly life-changing decision either way. And so giving them the space to choose whatever they want, because we don't give adolescents enough credit. They do have a huge and very sure sense of self a lot of the times. They can make choices on their own. But the barriers were already there pre-Dobbs with reproduction and reproductive justice for adolescents as a whole. And so now it's even harder to try to get them the care, which makes me fight harder.
I would say for me, with fewer places to access abortion and so many more folks coming to us from outside of the state, although it was clear before, the sort of magnification of the impact of poverty on pregnancy decisions has just really sort of smacked us in the face. I mean, the number of folks that we have coming to clinic without shoes on. We started a closet at the clinic because folks needed clean clothes, right? And so the impact of poverty on pregnancy decision and the amount of poverty that exists in our country has been, for me in these last couple of months, really an eye-opening sort of realization.
I think I've definitely had I've had the experience of seeing a lot of patients who are very relieved and thankful for their abortion, but there's also such a nuance in abortion in the care that we provide, and there are a lot of people who are making the decision to have an abortion where if they had more money, if it was a different time in their life, if they didn't have several other kids, if they didn't have an abusive partner, they might not be in the situation to decide to have an abortion. And there's that. So it can also be a really sad and oftentimes is a hard decision to make too. And so relief is definitely a thing that I see all the time, and knowing that it's the right decision, but it's also such a loaded, complex decision that we're often supporting people through.
I'm really glad that your patients have advocates like the three of you. I've been just really wowed by all of you today. Can we have a round of applause for these folks? You've been so generous with their time. You ready to move on to the Q&A? All right, we have one question here from an audience member. I am a medical student who is planning to start residency in OBGYN next year and plan to become an abortion provider as part of my work. What advice would you give to someone in my shoes? Or what would you tell your younger self about your involvement in this important work? Thank you so much.
Thank you.
Yeah, that's true. That's what I'm thinking. Congratulations, by the way. That's amazing. I think I would, as you're choosing where to train, I would try to center a place that is more supportive of abortion care, because you want to not only be able to do the advocacy work, which you can do really anywhere, right? Especially in more hostile states, but you want to be able to gain the skills. You want to be able to be around mentors who can teach you about their trajectory. And a lot of the times in certain programs that don't allow abortions, you'll have to go far and wide for that mentorship. So I would try to center where you decide to train, maybe UCSF. I would center that and where I choose.
I would say actually something you said earlier today, which is remember your why. There's a lot of hoops in medical training. You might wake up some days and think, why do I have to do this today? How is this going to help me be a better OBGYN? And so there's a lot of hoops to get through. And so remembering your why, and again, co-opting your word here, is going to be important to get you to the end goal, because it might not feel very close right now, but it is, meaningful and impactful on the other side.
I think just stay true to yourself as well. I mean, I remember when I was applying to residency, in my personal statement, I showed it to my dean, and I said, I said I want to be an abortion provider in it. And she was like, are you sure you want to say this? And I was like, yeah, if some place has a problem with that, then that's not the right place for me. So I think just, be honest in what you want. And when you're going through the process of finding a residency, is what is the training that people get here? And the places that you might want to go to, I think will show themselves to you.
Our next question. Given that abortion can be stigmatized or not talked about in higher medical education in certain states, in your experience, how do other doctors who are not abortion providers think about abortion? Dr. Peacock looks like she has something to say.
There unfortunately are medical providers who don't believe in abortion, and I did experience that a lot of times in Georgia, and patients would suffer from that. And so there would be someone trying to have pregnancy counseling or counseling about pregnancy options, and if a provider is biased in a certain way, they might not provide all the options for that patient. So that does happen still.
I would say for me, look for the doers. We're at a moment right now where people who aren't abortion providers, but also physicians, are more aware than they have ever been about abortion and sexual and reproductive health care. There's some non-abortion providing doctors in the audience here, I see. And so, find those people and elevate them, or, continue to push them and support them pushing their non-OBGYN spaces, because they are out there, and I think they're more aware and eager to do things now than they ever have been.
I think there are a lot of physicians who are excited to learn. Some of my colleagues were just recently involved in training some general surgeons who are really excited about learning how to do abortion. We're just like, how many abortions do I need to do to learn how to do it? How am I going to get competent?
That's a very surgeon thing to say.
Yeah. Yeah, they just wanted to know how to do it and the path to get there really quickly. So I think that there are people who are really excited about being able to expand abortion access, which is great. I also think this speaks to why it's so important to include abortion education in medical education, because no matter what type of physician you are going to care for people with the capacity for pregnancy. I'd say essentially everybody, maybe, yeah, Well, they see women too. Yeah, they see people with uteruses too. So I think everybody will, and everybody also will encounter pregnant people at some point. And I think getting that experience in medical school gives them a deeper understanding. I've had some physician patients that I care for who are like dealing with like complications in their pregnancy, and sometimes there's like a sense of shock, like, oh, is this a situation where like if I was in another state I wouldn't be able to get an abortion for? And it just it like really hits home when they get that kind of deeper understanding with themselves, like what it would mean if that reproductive right were taken away from them. So I think just expanding access to how we educate people across medical education is paramount.
Just as we would in the community.
Our next question, I love this question. If we lived in a world where access to abortion was guaranteed, what would be the next steps in maximizing the quality of abortion care? How could abortions be easier or more comfortable for the patient? Talk about abortion utopia. What would be, if access is guaranteed, what could we improve? Dr. Brown?
This is a really great question. I mean, I think there's so much work to do. I mean, abortion is so medicalized too, and it doesn't necessarily need to be. And sometimes going into medical spaces has been really traumatizing for people, and all medical care has perpetuated harms, including abortion care in a lot of places. So I think we have so much work to do to really move the needle to be less stigmatizing and create more respectful places and spaces and leave more room for patients, like in their process of coming to an abortion and receiving an abortion. So that doesn't really answer that question, but but I think just being more holistic, providing more avenues of support, doula care would be great to expand around abortion care, and being more supportive of like self-managed abortion or abortion outside of the healthcare system.
I completely agree. Nothing more to add.
Well, my wife's an anesthesiologist, so if I don't say something about pain management, I'm going to be divorced or something soon. So the truth is that a long time ago, abortion care was pushed out of hospital systems and into independent sort of freestanding abortion clinics, which for most people is perfectly appropriate and fine, and it is certainly safe. Some people choose to have their abortion experience without intervention or pain medication, which is fine, but others would really prefer to have that if possible. And some of the restrictions, again, my Missouri hat on now, a lot of the restrictions have been such that it makes it impossible for people having abortion care in a clinic that is not a hospital to have the anesthesia of their choice. And so many people do have an experience with abortion that is uncomfortable or painful even, and would prefer something other than that. So I would say, I'm still married, right? So, so I would say that we definitely have some work to do to address, for those who want it, some higher levels of sedation.
I do want to add something. I agree with the holistic care and everything that they both said. I would also think, in a perfect world for me, exactly what they said, but in a beautiful like birth center, maybe an abortion center or a reproduction health center where you can have abortions in a nice bed and bath, and also birth in a nice bed and bath. So that would be my utopia.
It sounds nice. This is a question from a non-physician. Being in the state of California and not being a physician, how can people help increase access to abortion for those for whom it's restricted?
So I would say the vast majority of need right now for folks who live outside of a haven or protected state is around logistics management. So there is a incredible grassroots network of organizations called abortion funds. Most restricted states have an abortion fund or a practical support organization. So if we're thinking about either donating time to do some education, some of them do education work, or if there are dollars to be donated, I would say that's a good place to put that, because really the work around access right now is in the acute time frame is around managing the logistics and getting people from the southern half of the country to other places where they can get that care.
Our local abortion fund is called Access Reproductive Justice. And so you can, sometimes volunteers will give people rides, give people a place to stay, again, the money, but access if you're, live here.
So abortion funds cover, for abortion patients, things like travel expenses, things like childcare. Sometimes it varies from state to state, but sometimes they're permitted to provide funds for the procedure itself, lodging. They are and often they provide other services like volunteers who can help you get someplace, help you have a place to stay. They are really, they're kind of amazing grassroots organizations that are usually all volunteer or have very few employees, and they do amazing work. So I would also like to shout out abortion funds. They are a wonderful thing that shouldn't have to exist, but I'm so glad that they do. So one more question is, in terms of expanding the providers allowed to assist with abortions, do you see such expansion in California and other states? Well, and will we see, I'm sorry, this poor person, I can't quite read your handwriting. Are we seeing, I think this person is asking whether there are expansions in the numbers of and kinds of providers who can assist with abortions in states like California versus in states where there are more restrictions or bans on abortions. What are you guys seeing in terms of who's providing abortion care?
There are many states where advanced practice clinicians, nurse practitioners, midwives, physician assistants can provide some scope of that care. So in Illinois right now, they can provide medication abortion, and we are really leaning on the administration to expand that to include procedural care as well. And it isn't just actually blue states. So Montana recently, in the last 2 years, expanded access to allow APCs. So it is, I think, a policy win that we could get in a variety of states. Now, if the state completely bans abortion, that's less useful, of course. But I do think it is a place where we're seeing a lot of growth.
Yeah, I completely agree. And in California, advanced practice clinicians can provide abortion, including doing procedural abortion.
And in Georgia, we have a 6-week abortion ban now, but a lot of our counties, like I said, don't even have OBGYNs, let alone people to man their emergency department. So we have a long way to go before we get there.
How do you think the Supreme Court overturning Roe will impact healthcare and women's rights as a whole beyond simply reproductive healthcare?
100%, yes. So states like Missouri make it such that you don't have to guess, we don't have to theorize. In the last 2 years, we've had several pieces of legislation and or regulatory attempts to restrict access to birth control, particularly to IUDs. So it's not theoretic. It is already happening in places. Georgia probably is in a similar place as Missouri. And so I think we should expect that access to things like birth control, absolutely access to things like assisted reproductive technology. So IVF pregnancy care, for example, is on the chopping block as well. So I think it will, it certainly will impact, a wide variety of care.
Also, provider decisions around life-threatening conditions like ruptured ectopic pregnancies. I know a close friend of mine just experienced that personally and was mismanaged in the state of Texas, and actually had a life-saving procedure in Vegas on just a random trip that she was there. And I don't think that if she was in Texas, where they were having an ethical decision about what to do for her pregnancy, had it ruptured there, I'm not sure if she would still be here. So it's very unfortunate that that's the case.
Yeah, I don't know if I have anything to add. I mean, pregnancy is just connected to health in general, and so I think it absolutely affects healthcare overall.
Our health outcomes, our economic outcomes, our educational outcomes, our whole lives are so wrapped up in this issue, and it is, I think, very frustrating to a lot of patients to have that be out of their control. This is our last question, or our last note card, I should say, because, in fact, this person begins, I'm not sure I have a question. I just want to say thank you for the work you do. Opening life avenues to so many people is simply marvelous. Thank you, thank you, thank you. I feel the same way. Thank you all so much. Thank you, everyone, for coming. Please check out the exhibit in the lobby. There's some really beautiful photography, and we'd love you all to see it. And thank you once again for coming out, and thank you to our panelists.